So small amounts of disruption of that blood definitely are taken care of by those anastomoses, and that's their whole purpose in being. But you get it too bad, and then eventually that system is not sufficient. This can cause esophageal varices, and I'll just say E for esophagus there, and hemorrhoids. And that can be, hemorrhoids can be either in the esophagus or in the rectum. Both of these are conditions where the venous, the veins in the surface of the organ are swollen, distended, painful, can eventually leak and cause either rectal or esophageal bleeding. There are some technical differences between varices and hemorrhoids, which I don't fully understand, so we're just going to say they're enlarged veins, can cause bleeding. It's not good. The end. Okay?
So this is when, yes, the anastomoses are working, but not, it's just too far.
It's too far gone, yeah. And then you also can have a syndrome called Kaput-Medusa. I think I'm spelling this right. Medusae. And this is when it starts backing up in the anastomoses around the umbilicus, and those surface veins become enlarged, and so the surface of the abdomen becomes very gnarled and gross looking. That's a medical term for you. So you can actually see the veins on the surface of the abdomen protruding. Okay, any questions?
Just wait.
Yep.
Coming against the pop. You're just enlarged.
Okay. So then let's switch to the nervous system. So then what's the overall structure of the somatic nervous innervation of the abdomen? Well, we'll do a brief overview, and then we'll talk about it more a little bit later in lecture. So in general, we have the intercostal nerves extending beyond the costal cartilage and innervating the anterior part of the abdomen. So you can see here the extension of the intercostal nerves. We also have branches of the subcostal nerve, T12, and of the L1 nerve that help innervate the inferior aspects of the abdominal wall. Now for the viscera, we have the autonomic nervous system predominantly, and so we have both sympathetic input and parasympathetic input. Sympathetic input accounts for about 1/3 of the overall innervation, whereas parasympathetic accounts for about 2/3 of the total innervation of the abdominal viscera. For the parasympathetic input, we have the anterior and posterior vagus or vagal trunks coming down from where they were in the esophageal plexus. Remember, the esophageal plexus kind of came together to form these vagal trunks, which pass down through the esophageal hiatus. They then branch out again and become part of the prevertebral plexus, which is this whole big knot here. And this is predominantly branches of the vagus nerve.
The anterior and posterior.
Okay. And then we also have the pelvic splanchnic nerves. Remember from the sacral region of the spinal nerves, and they also provide some of the parasympathetic input. For the sympathetic input, we have the splanchnic nerves, so here the greater, lesser, least, and lumbar splanchnic nerves, providing sympathetic input, and all of the ganglia here in the prevertebral plexus are the synapses, the location of synapses of these these splanchnic preganglionic fibers synapsing with their postganglionic fibers. So remember, the flanking nerves come directly out of the paravertebral ganglia without synapsing with the postganglionic fiber, like many of the other sympathetic fibers do. So then they synapse within these prevertebral plexus ganglia, and then their postganglionic fibers then go in and innervate the target organ. So. Okay, any questions? All right, so that finishes up that lecture. So then let's switch over to some regional anatomy of the abdomen, and I will bounce a little bit around compared to what your book is doing, but I thought it made a little more sense with my structure. So first we're going to start out with just a little bit more in-depth discussion of the different layers of the abdominal wall. So, obviously we have the skin, superficial layer, and then underneath that we have the superficial fascia, which is divided into two layers, the camper's fascia and the scarpus fascia. The camper's fascia is a fatty layer, has lots of fat in it, and but there was something else I was supposed to say about it. Oh, this fatty layer right underneath the skin. And then the scarpus fascia is a thin membranous layer without fat accumulation right underneath. They actually merge and become one layer down low in the abdominal wall. You'll see that in a later figure, I think. Immediately under that are our three layers of muscle, the external oblique, internal oblique, and transversus abdominis. Under that, we have the transversalis fascia, and then finally the extraperitoneal fascia, which is another fatty layer. The transversalis fascia doesn't have a lot of fat, it's a thin membranous layer, but the extraperitoneal fascia can have quite a lot of fat. So when somebody is becoming overweight and you see more of a abdominal protrusion of fat, so like beer belly, that's a lot of extraperitoneal fat, as well as visceral fat within the abdominal cavity. And then finally we have the parietal peritoneum, which is the final layer in between, or before we so what I'm looking for, enter, oh goodness, the abdominal cavity. So then let's talk about some of those layers a little bit more. So back to the scarpus fascia. So like I said, the camper's fascia and scarpus fascia kind of fuse. The camper's fascia kind of dwindles out and just becomes a little part of the scarpus fascia down low in the abdomen. But the scarpus fascia continues on into the perianal calf area and becomes is continuous with the superficial perianal fascia, also known as the polus fascia, and also the superficial penile fascia around the penis. So this is another reminder that really the differentiation between pelvic and abdominal structures is somewhat arbitrary. There's a lot of continuity between the two compartments. So then let's go through the muscles in a little more detail. So the outer layer is the external oblique. It runs inferiorly, so from high on the posterior side to low on the inferiors, or the anterior side. It as it comes and wraps around the anterior portion of the abdomen, it blends into its aponeurosis, or aponeurosis, however you prefer to say it. And basically, an aponeurosis is a broad, flat tendon. That is the definition. And so these abdominal muscles end in these aponeuroses that then become intertwined and intermingle to form the linea alba, so that center structure of connective tissue at the midline. Linea alba is important to remember, because that's often the site of surgical incisions in abdominal surgery, when they actually have to open up the abdomen. Okay. Something to note about the external oblique is that its aponeurosis extends and folds down around to help form part of the wall of the inguinal canal. And technically speaking, they say the inguinal ligament is actually part of this aponeurosis, but we'll just keep them as separate structures for our purposes. All right, so then if we remove the external oblique, we see the next layer, the internal oblique, and this muscle runs more parallel to the transverse plane, so wrapping around the abdomen. It spreads out so that the upper and lower fibers pass more, the upper fibers pass more superiorly, and the inferior fibers pass more inferiorly as they wrap around. It also ends in the aponeurosis and intertwines with the linea alba, as well as other structures. That's one insertion point that you guys should know. I mean, all of them run to the linea alba, so that one, no. They have additional insertion sites, but I just want you guys to know the linea alba for sure. Okay, and then the next layer in is the transversus abdominis and its aponeurosis. And its fibers run almost entirely along the transverse plane, which is why it gets its name, transversus. Okay. So just know that the structural differences of each of those muscles, and each of them functions to compress the abdominal contents. The internal, external oblique are also involved in flexion of the abdomen or the trunk. The transversus abdominis, not so much. Right. So then on the anterior wall, we have the rectus abdominis, and this runs from the pubic symphysis and pubic crest in that area up to the xiphoid process and the anterior surfaces, someday it'll show up, of some of the lower ribs, costal cartilages. It's there. Remember, it's intersected by these tendinous structures along the way. Excuse me, which is why we get six packs when we actually, which I never have had because I don't work out that much anyways. I always dream of it though, it'd be kind of nice to be that fit. Okay, also interesting and important to note is that the posterior wall of the the abdominis
Try
rectus
to
is
be
enclosed by a
strike
rectal
roll back
sheet,
of
the
those.
rectus sheet. And so with the posterior wall, you can see here, the anterior wall has been cut away because this rectus sheet is, composed of the aponeuroses of the internal, external oblique, and transversus abdominis. So rectus sheet.
And that is still, is that on the posterior, like on the back side? Does it go all the way around the body, inside?
What goes all around?
The posterior, the rectus sheet.
Rectus sheet? Okay, so I've got a picture that will show that.
Oh, okay.
Yes. So, just to note real quick that the posterior wall only goes about 3/4 of the way down the rectus abdominis, and then you've got an opening here straight through to the transversalis fascia. Okay, now to answer your question here, there's a cross section. So, the aponeuroses, some of them go anteriorly here at the higher parts of the abdomen, and others go posteriorly to form the anterior posterior wall of the rectus sheet, and then intertwine at the linea alba, and then down low, all of the aponeuroses fuse on the anterior rectus sheet area.
Okay, so the rectus sheath is just part of the aponeurosis.
Yeah.
Okay,
Yeah,
alright,
and they just give it another name because there's not enough names for you guys to know.
fine.
Yeah. Okay, so this gives us an idea of some kind of the layering, what it would look like there. And if we take a full cross section, you can see how it relates to the rest of the structures in the area. So here's our peritoneal cavity. You can see the 3 main muscles of the abdominal wall coming, or lateral and abdominal wall coming from their insertion points. A lot of them insert on the thoracolumbar fascia, so you can see how they're intertwining here with those fascial fibers, and then wrap around. You see the aponeuroses coming around here and fusing to make the rectus sheath there. And then you see the other layers. So here's the superficial fascia, the fatty layer, Camper's, and the membranous layer to the exterior of those muscles, and then the interior surfaces having the transversalis fascia, extraperitoneal fascia, and the parietal peritoneum. And remember, the parietal peritoneum is continuous with these folds here that are the visceral peritoneum. Kind of gives you some overall structure of how it's all packed in there, if you can see it at any point. Okay, any questions? No? Okay. So then let's talk about this extraperitoneal fascia for a moment. So that's that layer kind of between the muscles and the parietal peritoneum, and it is within this fascia that we get the regions, the preperitoneal. This is also known as the properitoneal in some circles. Surgical circles, I should say, and the retroperitoneal area. And remember, we have the retroperitoneal organs. So those are actually embedded in the retroperitoneal fascia. So that contains, say, like the kidneys and part of the spleen, part of the intestinal tract, also that are actually out behind the parietal peritoneum and out of the peritoneal cavity proper. So. So remember, and then the preperitoneal area is typically just referred to as part of surgical procedures, as more of a locational type, we're looking for a term. where like the pre-peritoneal fat layer is continuous with, say, like the fat in the inguinal canal, et cetera, et cetera. So, just to be aware of these terms would be helpful. All right, so then next question, how is the abdominal wall innervated? So like I said, we have continuations of the intercostal nerves, so you can see them wrapping out around. You can see on the surface the lateral branches and then anterior cutaneous branches of those. Is this doing it every time I write on this thing?
Mm-hmm.
It's a pain. Of the intercostal nerves continuing onward out into the abdominal wall proper. And here you can see kind of the border there where they're extending out past that. They also have the branches of the L1 nerve, so the iliohypogastric nerve and the ilioinguinal nerve that kind of follow that same sort of pattern, that branching and curving around, coming more inferior as they curve around the abdomen to innervate the abdominal wall. So then if we peel off some layers, we can see here the T12 nerve, subcostal nerve coming through here, the T10 nerve kind of coming through here, and this illustrates nicely that these nerves come, after they leave the costal groove, they've been traveling in that costal groove, they dive deep underneath the costal cartilage. So it's deep to the costal cartilage. And continue on around between the transversus abdominis muscle and the internal oblique muscle. So remember, in the intercostal space, what two muscle layers did the intercostal nerve run between?
Innermost and inner.
Inner and innermost, right? So those are the two inner layers, right? So when you come out into the abdominal cavity, or the abdominal wall, sorry, again, we're running between the two innermost layers, the transversus abdominis and the internal oblique, so staying within that same kind of corridor as it moves into the abdominal wall from the thoracic wall. So, between internal oblique, I'm just going to say internal O, and transversus abdominis. All right. And that then translates to our dermatomyotome. So T7, the T7 nerve comes in around and innervates this area of the abdominal wall. L1 comes down and innervates the lower part of the abdominal wall in some of the perianal areas. And T12 is just above that. Beyond that, the rest of this is kind of a rough approximation. There's actually quite a lot of inter-individual variation that occurs for the innervation of the abdominal wall. But we do know that T7 is kind of the top part, T12 and L1 are the bottom part, and the rest of it, well, they're in there somewhere kind of idea. So, for our purposes, we'll follow this map, but remember that this is estimated and approximate, and there is variation. All right, so then arterial supply to the abdominal wall. Like the nerves, it follows along that same kind of trajectory, following along the same sort of path as the intercostal arteries. So we have the intercostal arteries continuing onward. What's the word I'm looking for? Posterior intercostal arteries here continuing on into the abdominal wall in the lower part of the thoracic wall. We have the internal thoracic arteries, which are the branch off to give the anterior intercostal arteries. Remember that at the level of kind of just about the level of the diaphragm, they split into the musculophrenic artery, which remember supplies the diaphragm, and also the superior epigastric artery. And the superior epigastric artery is the one that supplies the rectus abdominis and other anterior structures. So. Okay. We also have the inferior epigastric artery coming up from a branch of the external iliac artery. So that branches off out here-ish. And it actually anastomoses with the superior epigastric artery. So here's another anastomosis. Yes, Stephen?
Is the musculophrenic artery anterior or posterior
To
the ribs?
it is posterior to the ribs. It runs
Posterior.
right along there. Kind of acts as a anterior intercostal artery to those low ribs.
So
And then-
both the superior epigastric and musculophrenic are kind of posterior to the.
Yeah, they hang it back there and then continue, like musculophrenic kind of continues on around this way and then
Okay.
sends some branches to the diaphragm, whereas that superior epigastric just keeps on heading down. Yeah. Any other questions? Okay. We also have the deep circumflex iliac artery, which helps supply some of the lower lateral portions of the abdominal wall. There's some others, but I want you just to know these ones here that I have pointed out. Okay, so here's just another image that shows where the superior epigastric artery goes a little bit better, where the inferior epigastric artery goes, and kind of the anastomosis between them in that area. We also see how the steep circumflex iliac artery is coming up to help supply some of the lower aspects of the abdominal wall. Okay, so any questions on the abdominal wall before we shoot off into the next topic? Nope, okay. So then we're going to talk about the groin area, the inguinal area. And remember we talked about last time the development of the inguinal canal. And I'll just revisit that briefly because I like the way this figure shows it. So we get this processus vaginalis protruding out. It's actually technically a fold in the peritoneal, the parietal peritoneum that then pushes out with the rest of the layers of the abdominal wall, so that this is important to note that all of the processus vaginalis has all of the layers of the abdominal wall represented within it, because it's just pushed out, an outpoaching of it. And then remember from last time the gubernaculum, that developmental structure that pulls the gonads from the abdominal. This is terrible. That'd be really annoying. I at least am looking at my tablet. You guys have to look at that. Ugh. So that pulls the gonads down from the abdominal areas where they develop into the pelvic cavity for the female, so that's where the ovaries end up. And then for the males, it pulls the testis down all the way through the processus vaginalis to the end of it, through that area that will become the inguinal canal. So this area here is the future inguinal canal. One thing I did misspeak about last time is that the for the male, the gubernaculum is not the spermatic cord. It actually pulls this testis all the way down to the bottom of the processus vaginalis. So the spermatic cord is basically that processus vaginalis that's coming through. And you'll see that better in some later figures that we have. The gubernaculum does, however, pass through the inguinal canal in females as the round ligament of the uterus. Okay, so here is another image. So this is of the male. So you have the spermatic cord coming out through the inguinal canal. So you see here the opening of the inguinal canal here on the outside of the abdominal wall is called the superficial inguinal ring. And then we have the opening on the interior aspect of the abdominal wall is called the deep inguinal ring. And these are just where the processus vaginalis is pouched out, so they're not actually holes. It's just like, so the deep inguinal ring is just that point where the processus vaginalis is pooched out, so it's that opening into that area inside what was the processus vaginalis. And the superficial inguinal ring is just where those structures then transition from being at the abdominal wall into the spermatic cord, or attaching to the anterior part of the pelvis in the female. So even though it looks like a hole here, it really isn't. It's just the folds of the tissue form that opening and ending of the canal. So this is the image, I think, that shows it best. So we have the abdominal wall here coming out each way, and so then the inguinal canal is just this short little guy here that shows the outpouching of the structures there. The deep inguinal ring, I better switch to a different color, is here, kind of as that area where they're pushing out. Those tissues are pushing out, and then the superficial inguinal ring is out here, right where those tissues protrude out past the abdominal wall, surrounding the abdominal wall. Okay, so then in the male, let's just talk a moment about the spermatic cord, because this will be helpful in our discussion a little bit later. And remember that we have the ductus deferens, which is the ducts for the sperm to come from the testis out to the structure of the penis during ejaculation. And then we also have the testicular artery, and the plexus of the testicular veins is called the pampiniform. See if I can say it. Pampiniform plexus. There we go. And then also the genital branch of the genitofemoral nerve. So we've got nervous tissue, we've got vessels, and we've got the ductus deferens coming through the spermatic cord. And remember, this is just the remnants, the basic remnants of the processus vaginalis. So let's see if we can, think we can get through hernias in 2 minutes? Do you guys mind if we wait?
We have a test.
Oh, well then let's just stop here then. You guys go get